All right. Hi, everyone. My name is Jay Pandya. I'm one of the PGY3s. I'm going to be talking to you guys about a pediatric MCI night at the Brooklyn Rave. This is part of the pre-hospital disaster lecture series that we started this year. Just want to give a shout out to Dr. Dukas, Dr. McMahon, and Dr. Reisman for helping me out with this. So you're in the PEDS ED. Junior runs over from CCT and tells you there's 10 teenagers that are being brought in from a rave, suspected overdose. There's some critical, some obtunded patients, some of them are walking around, but you don't really have more information. So what we'll be talking about is an MCI today, the organization internally of what you want to do to prep for this. We'll briefly look over triage systems and what EMS uses in that pre-hospital period. Then we'll take a dive into the rave drugs that are out there that are commonly used, how to manage their side effects, including the use and indications for gastric lavage, and any questions that you guys have. So what's an MCI? MCI definition varies, but pertains to a suspected number of casualties that exceeds the available resources. So at Kings County, we have our own definition of what constitutes an MCI. So level A would be anywhere from up to 3 critical patients and up to 30 non-critical patients. Level B kind of goes up from there, level C higher up, and then level D is more than level C essentially. So does our scenario constitute as an MCI? Yes, it does. Right, you have 10 patients coming in, you have 2 to 3 of them that are pretty obtunded, they're pediatrics, and you're suspecting an overdose. So who do you contact? What do you do? We have our in protocol at Kings County. It's over 100 pages. So in that moment, you're not going to be able to look over the protocol. You're not going to have time to review it or read it. But what you would do is you would contact the AOD, who would then become the incident command. And this is a protocol and system that is kind of in place. So go ahead, call the AOD. But then we also have our admin. So at Kings County, this would be Dr. Verma and Dr. Lino. You also want to get kind of CCT pulled into this. You have Dr. Beta, who's kind of taken over this role of CCT functioning, so you would involve him in this. And then at Downstate, it would be Dr. Mehta and Dr. Ozaki, who are pretty much available at any time when you have these kind of issues come up. So again, contact AOD, which is administrator on duty, who would then become incident command and help manage this MCI while you are working in the ED, and then let our admin know, because they'll be very helpful in helping you get whatever resources you need and also helping to coordinate everything. So you've all seen this organization of our resources on disaster day. So I'm not going to go into it much, but this is a general way of functioning on an organization that should happen. Now, obviously in low resource settings, like we work in, you make do with whatever resources you have at hand. So you're going to contact the AOD, like I said, and they will get things moving. But in the meantime, you have your charge nurse. So let them know, hey, listen, we have an MCI. I'm going to need a couple of nurses and techs from the pod, wherever you can pull them from. This is kind of emergent at this point. We need more hands, all hands on deck, right? Pull the OBS resident and the OBS attending, or grab one of the juniors from CCT, or if the pod's slow, or if there's an ortho resident, ultrasound team is there, grab a couple of them. Basically, whatever extra bodies you have in the ED, grab them, right? They're going to become your extra hands on deck. They'll help you kind of manage this. If there's an extra attending in pit or fast track or the pod, you can pull one of them in. And what you want to try to do is essentially set up 2 teams, right? You have your peds attending who's there already. Sometimes we have double peds attending coverage, which is great because then you kind of have that already. But if you don't, say you're on an overnight, there's always one attending. Grab another attending. You're going to have one attending that pretty much each attending will run sort of like one team, right? And you're going to pull extra residents in. You're going to have extra techs and nurses being sent over from other parts of the hospital. Now, if there's trauma involved that you know of in this kind of case, or you know that there's going to be a lot of critical patients or you foresee that as they're starting to roll in, level this as a trauma when appropriate, and also let the ICU doctors or the PICU team in this case know, listen, we have this coming in. We might need extra hands on deck, or we might call you down to come help if we need more people. Um, Ideally, after discussing this with Dr. Dukas, what should happen is you have one attending that should be managing the room, right? Managing the patients coming in as they're being triaged. And then you have another attending communicating uh, live with incident command to pull whatever resources we need. So there are several triage systems that are used by EMS to triage patients. One of them is START, Jump Start for pediatric patients, and SALT, to name a few. And then there's the modified START system, which FIDNY uses, which you see up here. However, none of them actually, none of these algorithms have been tested for intra or inter-rater reliability. And there's actually very little statistical evidence on which triage tools to use for out-of-hospital triage in settings of MCIs. There are some RCTs comparing the different systems head-to-head, however, only in sim settings. You're obviously not going to be able to use this in an actual MCI. In one RCT, paramedics were invited and randomly selected to either use SALT or Jumpstart. For their study groups, randomized, they watched a little PowerPoint beforehand, and then based on some triage algorithm cards, they were asked to assign triage categories to 10 pediatric patients in the simulation. And what they actually found in this was that SALT is as good as, is at least as good as Jumpstart. It's also important to be aware that in the ED that there's going to be multiple people calling EMS, and EMS might not know themselves that this is an MCI, right? So you might have one unit pick up a couple of patients, pick up a patient and come. They might not know that there's 10 other patients inside, right? So you might be getting more patients than you were called in for. And EMS might not even know the exact amount of how many patients they are. So just be aware, be ready to prepare for more than you were called in for. With this modified START system, we have 10 patients coming in, right? A couple are ambulatory, so they're going to fall into this green minor tag, right on scene. Then you have a couple that they're breathing on their own. They're not infants. These are kids that are between 15 to 18 that are at a rave. And they're not really tachypnic or bradypnic, so these are going to be red tags. Some of them are, but they still have a pulse, right? So these are also red tag patients. And then you might have some that are in that yellow. So for our MCI case, we're going to be getting kind of the whole spectrum of the patients that are ambulatory and intoxicated with this unknown substance, and those that are more critical, not really protecting the airway. So why is this happening? Let's go into some of the rave drugs. The most widely used club drugs are MDMA, also known as ecstasy, GHB, which is gamma hydroxybutyrate, flunitrazepam, which is Rohypnol, and lastly, ketamine or Ketalar. These drugs are popular. They're low cost. They're conveniently distributed as small pills, powders, or liquids. And they're usually taken orally, but they can be taken in a combination with alcohol, co-ingested with other drugs. It's important to know that these are often adulterated or misrepresented. They're also mixed in with a lot of other substances sometimes. So you really don't know what's in them. And therefore, any club drug overdose should be suspected as a polydrug use overdose because you don't actually know what they took. Of the club drugs that we're going to focus on today, MDMA and GHB are what I'm going to go into more, but I want to briefly go over ketamine and Rohypnol as well. Ketamine is a fairly quick-acting drug. It's a non-competitive antagonist of NMDA receptor, and it increases the sympathomimetic effects of dopamine, norepinephrine, serotonin, and GABA, and then it'll inhibit GABA. So in high doses, it'll cause this apnea, hypotension, bradycardia, stupor, laryngospasm. If a patient's coming in with a high dose ingestion by itself, consider intubating for airway protection. And if they're more agitated in the less severe overdose, then you can use Ativan to help sedate them a little bit. Activated charcoal can be used for GI decontamination if you suspect a large volume ingestion or co-ingestion. Ketamine's a pretty fairly fast on, fast off drug. Think of this as like us using it for RSI in our patients, right? Think of it as using ketamine in the ED, right? We see how fast the effects come on, or even for conscious sedation. Um, Having said that, if a patient has used ketamine and they're obtunded for a long time, you should start thinking about co-ingestions at that point. And then rohypnol is a potent benzo. This is going to cause your like sedative effects, and this is the only one out of the four that has an antidote, which is flumazenil. So MDMA. MDMA. This is what it looks like. These pills. They almost look like little like candies with these cool imprints on them. This is what the chemical structure is. It's 3,4-methyl dioxymethamphetamine. It comes in these different color like tablets. The drug acts as a stimulant and has some combination of amphetamines, caffeine, pseudoephedrine, and hallucinogens inside. MDMA works by increasing serotonin, dopamine, and norepi from the presynaptic neurons, and then prevents their metabolism by inhibiting MAO. So this can lead to the sympathetic overload that you see in these patients, causing tachycardia, mydriasis, diaphoresis, hypertension, makes them more prone to arrhythmias and hyperthermia, along with serotonin syndrome, which will present with rigidity, clonus, autonomic instability, rhabdo. You'll find renal failure, and when you get their labs, and in more severe cases, ARDS. It also increases antidiuretic hormone, which in combination with the dehydration from, if you think about rave setting, the dancing, the hyperthermia, hot settings, in combination with the increase in ADH, these patients are going to have hyponatremia as well. This drug is popular for its fairly quick onset. Usually takes about 30 to 60 minutes, and its duration of up to 8 hours. Once it's ingested, it's readily absorbed from the intestinal tract and then reaches its peak in the plasma about 2 hours after oral administration. It's going to cause agitation, a distorted sense of time, decreased hunger and thirst, followed by euphoria, a lot of insight, and it also acts as an intimacy stimulant, with some of the positive and desired effects that it's used for are the euphoria, the wakefulness, and the sexual arousal. Its mechanism is very similar to amphetamines, but at about 1/10 of the effect of amphetamines. However, at higher doses, it can cause the hyperthermia, hyponatremia, seizures, and SIDH, in addition to the other complications of serotonin syndrome. So, how do you manage this? First, always back to the basics, right? ABCs. So, airway and breathing. If this person with significant MDMA overdose comes in, you know it's MDMA, and they're not protecting their airway for a long time, use standard medications for RSI. You don't have to alter those. If you think about circulation, tachycardia and hypertension are going to be common in MDMA overdoses. You can treat these with benzos. For hypertension that's refractory to benzos, you can also use nitroglycerin or nitroprusside. Hyperthermia is something that's also going to be common. Ice bath immersions are great. Use external cooling, right? Grab those ice packs, put them on your patient. If you have this in conjunction with symptoms suggestive of serotonin syndrome, you can consider using cyproheptadine, which is what we use for serotonin syndrome. The dose would be 12 milligrams once for adults or adult-sized children, with 2 milligrams every 2 hours afterwards. And for kids, it would be 0.25 mg per kg per day, divided over 2 to 3 doses. And lastly,
IV fluids too.
What was that?
Oh, I was saying you could do IV fluids too, like room temperature, and you can always do an NG tube and put in fluids if you're not worried about aspiration, or you can put in fluids intrarectally too if you're really worried about hyperthermia.
And then lastly, seizures is something that these kids can have, especially if they have severe hyponatremia. You'll see that seizures is something that happens in a lot of these drug overdoses. So for this, 3% saline is indicated. Otherwise, if hyponatremia is not the cause, then you can use benzos. So let's talk about GHB now. GHB is known LSG, liquid ecstasy, grievous bodily harm, GIB, soap, scoop, nitro, a lot of different names. It's a derivative of GABA, but it's also a naturally occurring neurotransmitter and acts on both the GHB receptor and as a weak GABA receptor agonist, which I'll get back to why this is important. So it acts on two receptors. It comes as a powder, like you see in this bottle, dissolved in drinks. It's fairly cheap, making it one of the more commonly used ones. It's about like $5 to $10 per dose. As desired, it's pretty fairly quick onset within 15 to 30 minutes and peaks in about an hour with a long duration of about 6 hours. It works on both the GABA B and GHB receptors with a biphasic effect on dopamine. So at lower doses, it's going to stimulate dopamine release, causing all excitatory effects. But later at higher doses, it binds to GABA receptors, which causes the more CNS and respiratory depression effects. So initially, you can have some symptoms of euphoria, but usually with these overdoses, you're going to see a patient with dizziness, hypersalivation, hypotonia, and amnesia. And the more severe side effects will be seizures, coma, bradycardia, and hypothermia. And as far as treatment for overdose goes, it's mostly geared at supportive treatment. You protect the airway, maintain adequate perfusion pressures, give them fluids if need be. Bradycardia and hypotension are commonly seen in overdoses, and you can treat these with atropine and IV fluids. If you suspect opioid co-ingestion, you can also give IV naloxone here. As far as gastric decontamination goes, lavage is indicated if a high dose ingestion was taken within an hour of arrival with a suspected co-ingestion. Now, in terms of the use of activated charcoal, there really haven't been any in vivo studies that have been done for the use of activated charcoal for GHB overdoses, but there's been one in vitro study that tested the adsorption of GHB to activated charcoal, and what they found was that it's dose dependent, so better adsorption at higher doses of the intoxication, and it's pH dependent, which with higher adsorption in gastric pH compared to intestinal pH, which again supports the use of activated charcoal if you know that they've had this ingestion in the last hour before coming in.
When you see these overdoses, I've seen a couple of these at Lincoln. They're very impressive. They come out, they're completely out, and sometimes you've intubated them, and suddenly they wake up and rip out their ET tube, and then they go back down later. You got to really sometimes restrain and watch them, and then suddenly they wake up again. Very characteristic of the bad overdoses I've seen with UHB. They're totally out, and then suddenly they wake up and they're hyper.
Yeah, going along with Dr. G said, these patients, with GHB, they do have this kind of, because of the way the drug works, and the receptors it works on, they do have these biphasic effects, and a lot of times when they're coming out of their intoxicated phase, they will be very agitated and hyper. We're talking about these drugs just to know that if you suspect that it's just MDMA or just GHB, right? With a lot of these patients, also know that they've taken multiple of these drugs. So you might be treating the side effect of one, or if, say, one drug's effects kind of wear it down, then the effects of another drug might precipitate more. So again, if you're seeing one clinical presentation and all of a sudden it changes, it can also mean that there's another drug on board that's causing that. So let's talk a little bit about activated charcoal for GHB intoxication, which I kind of went into already. But again, remember, it is indicated. There's activated charcoal has a lot of uses that for sure work. There's certain molecules that it doesn't work for. So in this case, for GHB, it's worth trying, especially if you know that the ingestion happened in the last hour before. In CCT, now on the ped side, but on the adult side, I think in this case scenario, it's definitely worth kind of going into. It's not something we do that often. So the indications for gastric lavage are less than 1 hour from ingestion of a highly toxic substance or ingestion of a large amount of a toxic substance. Um, in our scenario, we have 10 patients. Um, for the case of the MCI, we're going to say that one of them was known ingesting uh, a whole bottle of pills of MDMA, about 15 of them. And this is a 16-year-old kid, adult built, who came in. And that's your most critical patient. And you have friends with him that say, yeah, we just got there. We were out on the first time. And he took 15 of them because he was dared to. This was 45 minutes before presenting, right? So you're expecting a very high overdose in this patient with pretty significant side effects once the drug starts getting metabolized. So what do you do? So gastric lavage for this patient, you want to secure their airway, right? There's a high risk of aspiration in these patients. So before you start the lavage procedure, secure the airway, intubate the patient. Now to do the actual lavage, you want to place the patient in a left lateral DQ position. The reason behind this is this picture you see on the top right. If they're on the left lateral DQ, the lesser curvature will be superior, and therefore when you put your OG tube in, it'll actually fall into where the gastric contents are, and you'll be able to aspirate better. Versus if you're putting them on the right, the lesser curvature, the way that gravity works, the contents are gonna go into the pylorus. So again, you want to keep them in left lateral DQ. You'll need between a 36 to 40 French OG tube for this. At County, it's a little different. We only have 32 French rigid tubes, which are the longest ones with the syringe setup that you see here. And we don't have them in CCT right now. We have them in the ORs. So you should send someone to the OR to get this. The way to confirm placement is you can use a pH testing strip. So any pH less than 5 will confirm proper placement. Or if you're like aspirating and you're clearly seeing gastric contents being aspirated, you know you're in the right spot. And then obviously the other way is to get a chest x-ray to confirm proper placement. So once you've confirmed proper placement, what you're going to do is introduce about 200 to 300 cc's aliquots of either saline or warm tap water into the OG tube, and then slowly aspirate it back out. So you continue to do this basically until your aspirate that you're pulling back out is clear of any particles. Now, for pediatric patients, you want to give aliquots of 10 cc's per kg with a max of the adult, which is 300 cc's. And once you do this, once it's clear, you can consider giving activated charcoal, which is going to be 50 grams for adults via the OG tube before you remove this OG tube. And for pediatrics, you can use 0 to 12. For kids between ages of 0 to 12, you can use 0.5 to 1 gram per kilogram. And for kids greater than 12, 1 to 2 grams per kilogram with a max of 50 grams. Now, some setups might be a little different for gastric lavage. So we have the syringe setup where you basically put the OG tube in, and you're standing there at bedside, and you're pushing aliquots in and you're aspirating back out. There's something that's a little more hands-off, which is basically this 2-bag setup. It's a closed system irrigation. So in this system, you connect the OG tube with a Y connector to a lavage fluid bag. And on the other end, you have a gravity bag that's connected just to gravity, or you connect the other end to a suction canister. And what you basically do is use a clamp, like you see on the right. You allow the desired amount of the lavage fluid flow into the stomach, clamp that tubing, and then allow the tube to empty out onto the other side. So either you suction it back out, or you just let it fall to gravity. You unclamp the bag that's attached to gravity, and you alternatively switch which tubing is clamped until you're completely lavaged the stomach. You're a little farther away from the gastric contents this way. It's a little more intense, like a little less intensive way to lavage. Just to recap now. So know your MCI criteria. We have this in CCT. I know there's a binder for MCI and activated. When you call the AOD, say I'm activating an MCI, we have an MCI to get things into play, but then also contact our administrators because they'll also help out. Dr. Verma, Dr. Lino, Dr. Mehta, and Dr. Ozaki. Know what your rave drugs are, especially if you have that. We don't really see this much. But in the case that you do see these massive overdoses, be ready for that, especially if you have a high number of critical patients coming in. Pull whatever resources you have, organize yourself in the ED, because you're on the ground and you're going to be doing it. So gather what you can. During the last case that we had, it was just one patient with this overdose, but they pulled basically everyone. They had one person run to downstate to grab this system, the closed irrigation system, because those bags were at downstate. We didn't have them at county. And then someone ran to the ORs to get the 32 French. So use your resources that we have on ground. And then just go over your indications for gastric lavage and activated charcoal. That's it. Anyone have any questions?
I just wanted to add, if you're calling the administration, also call Gus, because he can help mobilize the pediatric side, PICU and other resources.
I saw a question. First, Jay, great job. There's a question in the chat about Utox. I don't know its utility, because by the time you get it back, you should hopefully have resuscitated your patient. If the patient remains altered, then I think it is maybe reasonable to send it. The thing is, they're not very specific. They don't screen for like GHB. They don't pick up most opiates. And I always assume that there's usually an alcohol co-ingestion. I know it's not always the best assumption, but a lot of the times if there's an overdose, you have to worry about polysubstance. And then just whenever I do give a coma cocktail, or whenever I am treating patients that are a little more undifferentiated than altered, I'm pretty quick to give Narcan, and I'll nebulize it, as part of like pre-oxygenation in case I intubate while I'm getting lines to do other medications. I'll just put the dose in the nebulizer, put some saline in, and nebulize that. And that's kind of how I pre-oxygenate and potentially treat and buy time. Yeah, Paul says Utoxes don't test for fentanyl. I think the further you get in your training, the less and less you'll like the Utoxes. Subam, I don't remember. I think I just took the 0.4 and then I put like enough saline in it so that it'll nebulize successfully, and it's worked each time. I can't give it an exact concentration. Right? Maybe I saw Dr. Hassel was in the chat before. If Dr. Hassel knows, I've seen him do it. I've seen Dr. Gore do it. But great job.
Something else to add that Dr. Palladino brought up too, these are drugs that are commonly used in sexual assault. So once you take care of the intoxication issue and you treat that, always also screen for sexual assault, with your exam, talking to the patient